Cystic fibrosis. Cystic fibrosis (CF) is the most common fatal autosomal recessive disease. An individual must inherit a defective copy of the CF gene, one from each parent, to have CF. Although CF was once considered a fatal childhood disease, approximately 38% of people living with the disease are 18 years of age or older. Cystic fibrosis is usually diagnosed in infancy or early childhood, but patients may be diagnosed later in life. For individuals diagnosed later in life, respiratory symptoms are frequently the major manifestation of the disease. Pathophysiology. This disease is caused by mutations in the CF transmembrane conductance regulator protein, which is a chloride channel found in all exocrine tissues. Chloride transport problems lead to thick, viscous secretions in the lungs, pancreas, liver, intestine, and reproductive tract, as well as increased salt content in sweat gland secretions. In 1989, major breakthroughs were made in this disease with the identification of the CF gene. The ability to detect the common mutations of this gene allows for routine screening for this disease as well as the detection of carriers. Genetic counseling is an important part of healthcare for couples at risk. Airflow obstruction is the key feature in the presentation of CF. This obstruction is due to bronchial plugging by purulent secretions, bronchial wall thickening due to inflammation, and over time airway destruction. These chronic retained secretions in the airways set up an excellent reservoir for continued bronchial infections. Clinical manifestations. The pulmonary manifestations of this disease include a productive cough, wheezing, hyperinflation of the lung fields on chest X-ray, and a pulmonary function test results consistent with obstructive airway disease. Colonization of the airways with pathogenic bacteria usually occurs early in life. Staphylococcus aureus and Haemophilus influenza are common organisms during early childhood. As the disease progresses, Pseudomonas aeruginosa is ultimately isolated from the sputum of most patients. Upper respiratory manifestations of the disease include sinusitis and nasal polyps. Non-pulmonary clinical manifestations include gastrointestinal problems, example pancreatic insufficiency, recurrent abdominal pain, biliary cirrhosis, vitamin deficiencies, recurrent pancreatitis, weight loss. Genitourinary problems, male and female infertility, and clubbing of the extremities. Assessment and diagnostic findings. Most of the time, the diagnosis of CF is made based on an elevated result of the sweat chloride concentration test, along with clinical signs and symptoms consistent with this disease. Repeated sweat chloride values of greater than 60 milliequivalent per liter distinguish most individuals with CF from those with other obstructive disease. A molecular diagnosis may also be used in evaluating common genetic mutations of the CF gene. Medical management. Pulmonary problems remain the leading cause of morbidity and mortality in CF. Control of infections is a key in the treatment. Antibiotic medications are routinely prescribed for acute pulmonary exacerbations of the disease. Depending upon the severity of the exacerbation, aerosolized, oral or intravenous antibiotic therapy may be used. Antibiotic agents are selected based upon the results of sputum culture and sensitivity. Bronchodilators are frequently administered to decrease airway obstructions. Differing pulmonary techniques are used to enhance secretion clearance. manual postural drainage, chest physical therapy, high frequency chest wall oscillation, and other devices that assist in airway clearance. PEP mask that generate positive expiratory pressure. Flutter devices that provide an oscillatory expiratory pressure pattern with positive expiratory pressure and assist with the expectoration of secretions. Inhaled mucolytic agents such as Dornase alpha or N-acetylcysteine may also be used. These agents help to decrease the viscosity of the sputum and promote expectoration of secretions. To decrease the inflammation and ongoing destruction of the airways, anti-inflammatory agents may also be used. These may include inhaled corticosteroids or systemic therapies. Supplemental oxygen is used to treat the progressive hypoxemia that occurs with CF. It helps to correct hypoxemia and may minimize the complications seen with chronic hypoxemia. Lung transplantation is the option for small selected population of CF patients because there is a long waiting list for lung transplant recipients. Many patients die while awaiting a transplant. Gene therapy is the promising approach to management with many clinical trials underway. So medical management, first one is antibiotic treatment, bronchodilators use, and pulmonary techniques, chest therapy, physiotherapy, everything, and inhaled mucolyte agents, anti-inflammatory agents, supplemental oxygen, and last one, lung transplantation and gene therapy. Nursing management, promote removal of pulmonary secretions, chest physiotherapy including postural drainage, chest percussion, vibration, breathing exercise are implemented and are taught to the patient and to the family when the patient is very young. Importance of an adequate fluid and dietary intake to promote removal of secretions and to ensure an adequate nutritional status because CF is a lifelong disorder. Patients often have learned to modify their daily activities to accommodate their symptoms and treatment modalities. As the disease progresses, however, assessment of the home environment may be warranted to identify modifications required to address changes in the patient's needs, increasing dyspnea and fatigue and non-pulmonary symptoms. Although gene therapy and double lung transplantation are promising therapies for CF, they are limited in availability and largely experimental. As a result, the life expectancy of adults with CF, cystic fibrosis, is shortened. Therefore, end of life issues and concerns need to be addressed in patients when warranted. For the patient whose disease is progressing and who is developing increasing hypoxemia, preferences for end of life care should be discussed, documented, and honored. Patients with family members need support as they face a shortened lifespan and an uncertain future. Thank you.